right, so with that, we are recording. Questions are welcome in chat. And I will leave it to Dr. Natalie Noonan. Thank you very much for joining us tonight.
It's my pleasure. Thank you for inviting me. I've been looking forward to this. Okay, so just on two different monitors, so I'm kind of jumping around. Okay, so definitely please ask questions as we go. I think it's a lot more helpful for everybody when we're talking about something and someone has a question about that specific slide or that topic, and we can have a conversation. But now that I've shared my screen, now I can't see the chat box anymore.
I can keep an eye on the chat box for you.
That'll be great. And then if you want to just, if you can just interrupt me, maybe I'll pause at the end of each slide and ask if there were any questions on the chat box, and we can, does that sound good? Like a good plan?
That works for me.
Because I can't see myself or the chat box anymore. So, okay. So, so tonight we're going to be talking about neuropsychological assessment of children with subtle autism spectrum. I put quotes around that because I'm not sure everybody would necessarily agree that you can call autism spectrum subtle or not. And I also want to preface this whole thing with, I am not on the spectrum. I don't have autism. I am a neuropsychologist who works with a lot of people with autism, but I am very open to learning from another perspective. And so if there's anything that I say that I can learn more about a different perspective, please let me know. That is what I want. So so we're going to be talking about that, and I hope by the end you come away feeling like you know what to expect from a neuropsych assessment, with the primary reason for the assessment being related to autism, what to ask of clinicians when you're going into the evaluation, while you're having the evaluation, and then afterwards. And then ongoing, what to expect from an ongoing relationship from that clinician, and then how to interpret the report, because the report is kind of the product of the evaluation, and it's an important piece, and it can be kind of inaccessible, I think, to some people. And that is the fault of the clinicians, because we are trained to create these monstrosities of reports, and they're not that easy to read. So I think the goal for most clinicians is to be moving towards a more accessible version of that document. So I want you to come away knowing what to look for in the report and how to understand it. Okay, so who am I? So my name is Natalie Noonan. This is a little bit about my training.
Real quick, your screen is not sharing with us.
Oh.
And I think that is supposed to be one of the first slides, and I'm not seeing it.
Hold on. Oh, start sharing. Here we go. Thank you for telling me that. I forgot to click. Is it sharing now?
It is sharing. You may want to put it into display or slideshow mode.
Okay, is that working now?
Perfect.
Okay, great. And I can see myself now. Okay, so that's the title page. So what to expect as a parent, what to ask of clinicians, and how to interpret the report. Okay, so who am I? So Natalie Noonan, this is my training. I went to Emory for my undergrad. I studied neuroscience and behavioral biology there. Then I stayed there for graduate school, where I got my doctorate in clinical psychology. I was at Johns Hopkins at Kennedy Krieger for my internship, and then at Brown for my postdoc for 2 years. And then I stayed at that hospital for a while as a staff neuropsychologist, working at Bradley Hospital and Rhode Island Hospital. And now I have my own private practice where I see people with different types of, lots of different referral questions. I try to focus on coming from a perspective of neurodiversity, and most of what I do is evaluation. Okay, so the first thing I wanted to talk about, because it's really important to me, is what is neurodiversity? And I think one of the biggest value, one of the biggest values for in the neurodiversity movement is depathologizing and moving away from this idea of diagnosing and fixing and curing. And that's really important to me. So that's kind of what this talk is kind of framed within. And some things I think about when I think about neurodiversity are who's being asked to change. So when we diagnose somebody, what are we asking them to change? Or are we asking the world around them to change for them? Or is it a combination? And who holds the power within that dynamic? Most of the time, in my experience, because I work with kids, it's kids. And the adults in their lives are bringing them in because something is not right or something doesn't feel right. And so there's a power dynamic there, and then there's a power dynamic between the clinician and the people that are coming to see us. And so the people that are being diagnosed are at an automatic disadvantage in terms of power, and so they're being asked to change frequently. So the movement of neurodiversity is kind of in an effort to kind of rebalance that a little bit. And I think about this quote a lot. This quote is, I don't know if you guys have heard of someone named Ari Ne'emen. I don't know if I'm saying his name correctly, but he is, he's kind of he's an advocate for people with autism. He has a diagnosis of autism as well. And he did a presentation that I've linked at the end that is very interesting, and you guys should definitely watch, about operationalizing neurodiversity. And how do we use that term to make it more functional for the people that it refers to. So this quote, I'll just read it. It says, it made me angry and sad and frustrated because I never stopped being autistic. I just learned how to get around in a neurotypical world better. These days, I'm pretending to be normal for them, not myself, and that's what hurts. So I think about that a lot when I meet with families and when I am evaluating kids and when I'm thinking about the interventions for them. Any questions so far? I don't see the chat box, so I'll just wait. Jesse, just interrupt me if.
Sure, will do. I think everybody's all good at the moment.
Right.
I know that there has been, I'll just comment, a change between saying that someone is diagnosed with autism and talking about it as identifies as autistic or has been identified as, I think actually that's the big motion is towards using identity first language.
Yes. And so instead of saying an autistic person, we say someone with autism or someone who's been identified, which is more of a mouthful, but it's person-centered. So it's kind of it's taking the focus off of this aspect or this piece and focusing on a whole person.
Yeah, because when you talk about it as something that someone has, then it's like, oh, well, you could take it away and they'd be fine. And that's not right. And like, that's not who they are. They are who they are.
Exactly.
So anyway, that's,
yes.
It looks like somebody has their hand raised.
Okay.
Add to what Jesse is saying, I think it's similar, I guess, to the new trend saying, instead of saying people with disabilities, I was reading people say people with different abilities. And I feel like it sounds much better. That's kind of in that area.
Yes, I've heard that. I've definitely heard that. And then I've also heard another side of people with disabilities responding to that, saying, I have a disability and that's okay. I'm not trying to brush that under the rug, or I'm not trying to make that what it's not. There are things that I can't do, but I don't want to be stigmatized for that. So everything is, everybody feels differently, I think, about how to talk about these things. And it's important to be open to the changes that things that we're learning as we go along. But the most important thing is these are people. We're talking about people, and not trying to fix or cure something, I think, is kind of the biggest take home from this neurodiversity movement. Ari is he's remarkable, and I'd encourage everyone to kind of look him up and watch. He's got some interesting videos on YouTube and some interesting work. Okay. So what is a neuropsychologist? So I just kind of start with this stuff because I don't know how much people know about what a neuropsychologist is, but so I'm a pediatric clinical neuropsychologist. We have specialized training in brain behavior relationships and brain development in children, adolescent, and young adults, specifically in that age range. The training is used to evaluate brain disorders or differences, and it may involve a brain injury or a disease or developmental differences like autism or ADHD or other things like that. Referral questions that we get are things like, they can range from social, emotional, academic, neurological, and adaptive functioning, and they usually span all of those things. And that's why someone needs a neuropsychological evaluation, because it's a complex referral question. You need to have a doctoral degree. You need to have a 2-year postdoc following that at approved sites. And then some clinicians become board certified. Typically that's in hospital settings. And I also want to, tying this slide back to the last slide, is I was trained in kind of a medical construct where these are diagnoses. And in my work with families and children, I've been moving away from that, but my training is still there. So I'm kind of retraining myself to move away from saying things like, diagnosis or this person has. So forgive me if I slip up. I'm still learning. I'm still moving forward. Okay, so what do pediatric neuropsychologists do? We help. So we understand how neurodiversity may relate to difficulties seen at school, home, or with peers. We help help understand how a child may learn best. So their learning style may be different from the way that what's being presented to them at school or at home. Help understand why a child may be having a behavioral difficulty. Help a child understand their own thinking or the behavioral differences. Identify neurological or psychiatric differences or problems. And then I think the most important thing is matching expectations with a child's specific strengths and weaknesses, matching those with the expectations with their environment, and communicating with other professionals as well. So why would someone with potential who may have autism need a neuropsych? Why wouldn't you just go to your pediatrician, or why can't the school diagnose it, or someone else? So I believe not for all people with who have been identified as being on the spectrum. They don't all need a neuropsych, but I think it can be important because oftentimes, because of the neurodiversity, there's kind of complex learning strengths and needs, and that can look like having attentional difficulties, learning disabilities, other things that a neuropsych evaluation can evaluate in a comprehensive way that you wouldn't get in a pediatrician's office. And then we might miss those areas and then not be able to support the individual in those areas. The other reason is to connect to services. And that's what happens at the end of the evaluation process, where we connect and give recommendations. So, for example, recommending speech and language therapy or occupational therapy, or making recommendations for the IEP and things like that. Okay, so what does the process look like for a neuropsych evaluation? This is different for all clinicians, but in general, it kind of follows these steps. So usually there's an initial call. So you get a referral, you call or you email the clinician, and you have a quick call with them, make sure this is a good fit, that your goals match what they can provide for you, and vice versa. Then once you've established that, there's a lot of paperwork. There's HIPAA, so it's a kind of privacy contracts, consenting, releases of information that allows the psychologist to talk to the school or the child's therapist, or any other professional that would be helpful for the psychologist to talk to. And there's an intake meeting, and that's where the psychologist takes a detailed history. And typically you talk about pregnancy history, birth history, early infancy, and then all the way through present. And it's broken into different domains that information is gathered within. So there's academic. So we ask about academic history. And that can look like, when did your child start being supported under an IEP? What did it look like? Why did that start? What are their grades like? What usually happens in school? History of social development. And then there's specific questions depending on the referral question. But if it's an autism evaluation, usually there's questions about sensory sensitivities. So when did that start? What did they look like? How did they evolve? Restricted and repetitive interests, describing those. When did those start? How persistent are they? What's the content? And then any kind of repetitive behaviors or movements would also be asked about. And that's important to ask about that from the entire lifespan of the child, not just currently, but from the very beginning. And sometimes a classroom observation happens, not always. Sometimes it's important. For autism evaluations, it tends to be helpful. And it's useful to see a child in a structured and unstructured setting, a social component, and a transition. And that usually happens within an hour or two of school. So it can look like a group work, and then there's snack, and then there's kind of work on your own for a little while, make sure you finish your worksheets, and then there's lunch and recess. And it's really important to observe kind of that whole span of those different components during the day, because for a child with autism specifically, they can have a hard time transitioning between those activities. They can have a hard time with some of them and not others. And I'll talk a little bit more about why the observation can be useful in some cases. And then a feedback meeting is at the end, and that's when the psychologist describes the results from the testing, from all the questionnaires, from everything, the entire evaluation, talks about diagnoses, recommendations, and then questions and conversation. It really, I think, in an ideal world, is a conversation with the family, and if the child is there, talking about, does this seem to fit your child? Do you feel like I captured them? What questions does the family have? Having a conversation around that, and then connecting to resources. Oftentimes multiple feedbacks can be helpful, especially if it's a new diagnosis. If the child is involved in the process, it can be helpful to have multiple feedback meetings, because the family can go home and talk about the results together. And then after a couple weeks, information settled in, and it can be really helpful to then come back and ask more questions to the neuropsychologist, have more of a conversation. And I think we're doing okay on questions so far. Okay, so here's a little bit.
Sorry, I'm gonna jump in.
Sure.
And someone else has a question too. But I recall when our family worked with you, that your version of a detailed history is a little different than the neuropsych evaluations that we had in the past, in that you were asking about things in a different way, and in ways that maybe we hadn't necessarily thought like oh, that one thing, that little finger movement that we see is actually a repetitive behavior. It's not maybe a large rocking behavior that, it might be a classical repetitive motion, but it's this little repetitive motion. And I would have never thought to include that as a yes under does child make repetitive motions. And so I think that that's a little interesting in some of the ways that you come about how you do your intakes. So hoping that you can talk a little bit about that, but I think this other comment actually probably relates as well. And the question is, I've never understood the pregnancy and delivery questions. Can you give an example of when a detail from delivery or pregnancy has helped you make a diagnosis that wasn't known before?
Yeah, so that happens more with, so if there's something related to like birth trauma where there is there's some kind of distress, like fetal distress that's happening, or if there's difficulty with breathing or oxygen, that's typically where the kind of delivery questions come in. Or did something happen during pregnancy? Was there a certain medication taken? Was there a physical trauma that happened during pregnancy that could be important in understanding the whole process? Sometimes something like cerebral palsy or those types of things that happen around delivery can be helpful in understanding. Like cerebral palsy can be incredibly subtle, and it can be kind of brushed off. And there's been times where cerebral palsy was diagnosed much later, and it might have looked like a repetitive movement, or it may have looked like posturing when really it was more of a cerebral palsy presentation. Does that answer that question about the pregnancy? It doesn't usually change a diagnosis. It's more adding to the kind of a broad picture of what the family, has been dealing with from the very beginning. And then talking about, the asking specific questions, Jesse, that you were asking about. One thing I think that happens is families get so used to they know their child so well that that can be a blessing and a curse sometimes, because some things become almost invisible because you're just so used to seeing that, and it's just become part of everyday life. And then when someone comes in and asks specific questions, you realize, oh, that's something notable. That's something that's part of this big picture of possible autism. Did that answer those questions or address? Okay. So what's next here? Okay, so the observation. So I started doing, in my own practice, I started out doing observations more recently. It was always something I wanted to do. And this was one of the reasons I actually left the hospital setting, was because I couldn't do classroom observations in a hospital setting under insurance coverage. And with the time constraints that you get put on in a hospital, you have so many evaluations to do in such a short period of time. There is no time for stuff like going to a school and watching a kid for 2 hours, even though I would want to do that. So that was one of the big drivers in me starting my own private practice, was to do stuff like this. And I had it as an add-on in the beginning, but no one was kind of requesting it. So now it's just, I've changed it to be a part of my typical evaluation. I always do it unless a family says they don't want me to do it. And I changed it because it's been so helpful and useful to see kids in the classroom. And I really think it's really hard, I think, for some clinicians to do this because it is time intensive. It takes up a lot of time to drive to a school. Last week, I drove to Western Massachusetts. It took me 2 hours to get there, 2 hours back, and I was there for 2.5 hours. But it was so worth the time, because seeing a kid in your office where it's a one-on-one situation, the lights are dimmed, there's no distractions, it's very sensory friendly, there's not other kids around. It's a completely different environment than how they are in school. When they're in a classroom and they're in recess, or they're in lunch, or they're being asked to do group work they're in a noisy classroom, they're walking from class to class. Those are just such rich opportunities for observation, for information gathering. That's completely different from kind of the simulated environment that we try to create sometimes in my office. So not all clinicians do this. I find it incredibly helpful for a lot of families. Any questions about the observation?
There's a follow-up on subtle signs, and I think that you'll probably get to this a little bit later. So if we need to hold this one, that's fine. But the question is, following up on subtle signs, can you talk about some things that you look for in a very subtle presentation of autism as opposed to a dramatic one, like examples of things that you've noticed that might have easily been missed, so that we can all look for some of those things as well?
I will 100% be going over that. That's a really important question. We're definitely going to come to that. Okay, so, and I'll talk about a little bit of that right now when I talk about why the observation is important. So some things that I have noticed in observations are when a child is getting overwhelmed, or they are showing signs of anxiety. When does that happen? Does that happen when are they showing some kind of avoidance behaviors? Are they showing that when there's an increase in social pressure? Like, are they being asked to do some group work? What do they look like when they're doing group work? Are they hunched over? Are they kind of like covering their pages? Are the other kids trying to interact with them and they're having a difficult time? Are they trying to interact with other kids and they're having kind of unsuccessful attempts? Like I observed a child a couple weeks ago in preschool, and he was trying repeatedly to have interactions with kids, but he was getting too close to them and he was putting things in their face, and they didn't like it, and he wanted to interact. He just was not doing it effectively. So he kept getting shut down. And then after 2 hours at the end, one kid said to him, "We don't want to play with you." And he said, "Yes, we do. We do want to play with me." And that was really interesting too. So he kind of his perspective taking of, yes, we do all want to play, not that they don't want to play with me, was really interesting. And watching him make all these attempts and then being unsuccessful for some pretty specific reasons was really helpful in me explaining to the family what I saw and what might be helpful moving forward. So other helpful things for classroom observations are, what does the classroom look like? Are there things that we can change about the classroom to make this more supportive for the child? How loud is it? How bright are the lights? Is the door open? Are the windows open? Are there things that we could adjust to make it more friendly for the child and all the kids, really? There's another kid I saw who had mild hearing loss in one of his ears, and he was seated in the back of the classroom, and his most functional ear was facing away from the teacher. And that was an easy fix that we wouldn't have noticed if I hadn't watched him. So looking, where are they sitting? How distracting is the environment kid sounds? Because that when we get reports from the teachers, I always send, and clinicians will always, or should always be sending questionnaires to teachers. And you get the teacher's perspective back, and it's totally different from the parents. They're seeing the kid in a different environment than the parent is. And if me as a clinician, if I'm not seeing what the teacher's seeing, it's very difficult for me to understand why they're giving me that feedback. The other really nice thing about doing an observation that I've learned over time is that you develop a relationship with the teacher and the school, and that can make giving recommendations much more effective. And the recommendations aren't just coming at them from this random person who's seen the kid once and they've never met. But when there is kind of the beginning of a relationship because they've met me and I've taken the time to go in, I think they feel respected and they feel heard and listened to, and the recommendations are more individualized, and so they're able to follow through on more things. And I think there are many clinicians that are doing classroom observations for these reasons. Okay, So here for the testing day for a neuropsych evaluation. So the first thing is prepping the child. So having a good night's sleep, making sure that there's an agreement on whether medication is being taken or not. Sometimes a child will be on ADHD medication, and you should always talk to the clinician about whether that medication should be taken for the evaluation or not. Sometimes it is, and sometimes it's not. Having a good breakfast, if that's part of the usual routine, having snacks brought to the evaluation. There should be a lunch break if the evaluation is a full day. Water, sweatshirt, things like that. Sometimes it's important to have special objects that go in with the child into the room, and they should be allowed to do that for as much of the evaluation as that can be done for. And then preparing your child. So you're going to an office and you're going to be doing some activities, and your job is to do your best. Some things will be hard and some things will be easy, and that's normal. That's how it's supposed to be. We're learning how you think. Usually that's enough for kids, but giving them an opportunity to ask questions about it and telling them about it beforehand can be helpful. Letting the clinician know if there are any specific needs your child has before you get there can be really helpful. So if they're sensitive to sounds or lights or smells or certain things, then the clinician can make sure that the environment is as comfortable for them as possible. And then you have the right, and you should be asking about what the clinician is going to be doing. So what tests are going to be done? Why are they doing those? How long is it going to take? These kinds of things are it's not this magical box that's happening. I mean, you can ask why the clinician is doing certain things, and most of them are very happy to talk to you about why, probably too happy to talk to you about why. And then beforehand, I think, again, it's important to talk about your expectations. What do I expect the day to be like? What do I expect to get at the end of the day? Sometimes clinicians will give brief feedback at the end of the day. Sometimes they won't. Sometimes parents expect to know kind of results before they leave the testing day, and they go home and they don't have anything in their hand and they don't know anything. And that can be kind of a disappointment and can be confusing. Sometimes that's not the case, and clinicians are able to give them kind of an idea of what's coming. So kind of having your expectations before you go in. And then what does it look like for the parents? So it depends on the age of the child. For young children, 3 and under, 4 and under, and depending on kind of their development, typically the parent, if it's that young, the parent will be in with the child in the room for at least part of the evaluation. And the clinician will let you know how much you're going to be in there for, what you're going to be doing, what you're expected to do. For the most part, you wouldn't be helping the child unless the clinician asks you to. You're more kind of a comfort, or kind of, you're just kind of being there because the child is with a new person in a new place, and that can be scary. There are certain assessments where the parent does become involved in part of it, and the psychologist would let you know about that beforehand and let you know exactly what your role would be. And then usually for older kids, the parent is in the waiting room, or they do a drop off, and that kind of depends on the comfort of the clinician, the comfort of the child, the comfort of the parent. Okay. So I'm going to kind of zip through some of this stuff now. So we can get to some of this stuff at the end, but please continue asking questions. I want to make sure that we get to things that you guys want to hear about. So evaluating autism within a comprehensive evaluation is really important. So it's not just a questionnaire. Evaluating the autism piece should be sprinkled throughout the evaluation, and then there should be specific things that are related to the assessment of autism. So one of the things that's usually done is something called the ADOS, and that's the Autism Diagnostic Observation Schedule. It's a standardized kind of gold standard assessment for autism. It's play-based. It's done with the clinician and the child. If the child is younger, or depending on their language abilities, the parent is involved. And that's what that is doing, is trying to simulate what I was talking about before, simulate some social situations to kind of assess how the child responds to those simulated social prompts and opportunities. And so during that assessment, the clinician is observing things like eye contact, gestures, different types of gestures, how the child responds to what's called bids. So the clinician might say, man, I had something crazy happened to me, and then just kind of wait and see. And that's called a bid. And there's little activities throughout the ADOS that are used as prompts to help elicit certain types of social behavior that the clinician looks for. And then there's questions within the ADOS that you're asking the child depending on their developmental level and their language ability. Things like, what is a friend? How do you know that someone is your friend? How is a friend different from someone that you just go to school with? Things like that, trying to assess their understanding of social relationships, trying to assess their understanding of their role in social relationships. This can be really helpful. For kids with subtle autism, this can be sometimes not as useful because kids with subtle autism, and people with subtle autism can know a lot of the answers to these questions, kind of pass or camouflage, what they'll talk about in a little while. So that's why it's important that this is just one component of the evaluation. Questionnaires. So questionnaires should be going to parents. They should be going to the child if it's appropriate. They should be going to teachers as well. And then structured interviews with, so kind of an interview with the child and talking with the family. And those interviews can happen kind of sporadic. They can kind of happen in pieces throughout the evaluation. They can happen all at once. Kind of depends on the type of information that's being gathered. And those interviews, what's being asked during those interviews depends on who is being spoken to. So like for the child, you might ask things like I mentioned about friendships, feelings. Do you feel lonely? Do other kids feel lonely? Do you ever have a difficult time getting along with people at school, people at home? Do people ever irritate you? Do you ever do things that irritate other people? Things like that can kind of get at some of those perspectives. And then when you're asking parents and teachers, it's different questions. And in parents, a lot of the questions have to do with historical information. You're trying to gather information from when the child was younger and then all the way up to current. The observation at school I talked about, gathering the history is incredibly important. It takes a long time, and usually there's a history form that's provided, and the family will go through the history form, and then the clinician will go through that history form with them again, and kind of pull out information and ask them to talk more about, oh, you said that they have a sensory sensitivity to noise. Tell me more about that. One of the questions I usually ask about noise sensitivity is, are they sensitive to loud noises? Often, yes. Hair dryers or toilet flushing or the hand dryers, but what about noises that aren't typically considered aversive but bother that child? So like laughing or singing or whistling or a baby crying or something that's really difficult for them to tolerate, that may not be kind of objectively difficult to listen to. And then things like we mentioned before, some of the hand posturing. So a lot of the typical stereotypical things are like the hand flapping, but then some of the other things that you look for is called hand or finger posturing, and it can look like this, and kids can kind of put their arms at their sides and do it low down, so it looks kind of like this, and sometimes their hands are just kind of. And so that's not all, that doesn't mean a kid has autism. It's just part of a picture. It's a detail that kind of goes into a larger picture. Things like toe walking, all those things should be asked about. Sensory interests. So does the child like deep pressure? Does the child like to bump into things? Do they need deep hugs? Do they like to be squeezed? Do they squeeze other people? Do they like specific textures, and do they rub those things, repetitively? Is that soothing for them? So there's all things that I would ask parents and ask them, not just now, but did they ever have those sensitivities or seeking those sensations. Okay, and then I think listening to teachers is incredibly important. I like to call, if I don't get a chance to talk to the teacher when I observe, I always call the teacher and talk to them. And this has changed a lot since I started my own practice, because I think initially I thought people would ask me to do this, but I've been requesting to do it more, because it's just been such an important part of the evaluation process. Okay, autism criteria. So we're going to talk a little bit about the autism criteria and what it looks like for more subtle kids in a minute. So for autism, you're required to have weaknesses or differences in 2 core areas. This social communication, and then restricted, repetitive, and or sensory behaviors or interests. So there's kind of 2 buckets you need to have. If you only have social communication weaknesses, then that's something else. That's something called social communication disorder. You have to have both. And the difficulty or differences have to be in both areas, and the characteristics are evident from early childhood, even if they're not recognized until later in childhood, and that's important. And I don't know, there's in the DSM, there's levels of autism, and parents often ask me about the levels, and I really don't find the levels that helpful. And a lot of clinicians, I think, don't find the levels that helpful. I think the levels tend to be a little pathologizing, because it goes into this idea of kind of severity and curing and fixing, because if a kid is more severe, then the goal is to make them less severe. The idea is to understand how much support they need, but I don't find it to be that useful. It also gets into this idea of high functioning and low functioning.
Keep going.
High functioning and low functioning is also another kind of misnomer, and I don't think it's that helpful for families and for individuals to think of themselves as high functioning or low functioning, especially for autism, because someone can have a very high IQ but have a very difficult time doing daily tasks, and so are they high functioning or low functioning? I don't think it's I don't know if you guys have any thoughts on that, but that's one of the things I've kind of changed over the years. So some of these things for subtle autism can be missed. So the sensory sensitivities, the restricted interests, the repetitive behaviors, those can be very subtle, or they can be present in early childhood, but the kid has learned to mask them or suppress them. And so unless a very detailed history is taken, an observation is done, I think in the office, some of those subtle things can be missed. Okay, and then another reason for the neuropsych is there's other things that go along with autism that should be part of a neuropsych evaluation. So motor coordination should be looked at, because motor coordination is often an area of weakness for children who have autism, and ADHD, and different attentional differences and executive functioning weaknesses. These are different. You can look at this. You guys are gonna, I think we can send the slides out, so you can look at this on your own, but ADHD should be evaluated for as well. And then learning disabilities too. So if there's no difficulty in school, then there's not a big need for this, but kids who have autism often have weaknesses in learning areas at school. And then let's see how we're doing on time. Okay, so feedback. So during the feedback, I think a lot of clinicians are moving towards a more conversational feedback style, where we talk about the results, we talk about the recommendations, but it really is a conversation to make sure that the family understands things, that we as clinicians understand the family and what they're looking for, making sure expectations were met. And if they're not met, how can we help them get met? Connecting families to resources is really important. So connecting them to organizations. Do we need to look at speech and language? Do we need to look at social groups? Do we need to look at group therapy, family therapy? Clinicians can make recommendations for those things. We talked about high functioning already. And then one thing I think is important is you can ask the clinician, when will I get the report? And sometimes that is kind of a weighted question because that can take a while, but you have the right to know when you should expect the report, and then you can follow up at that time about when if you don't have it, you can ask politely when is the report coming, and you have a right to ask that. You shouldn't feel bad about asking a clinician about when that's coming, and you should get a soft and hard copy of the report. Let's see. Okay, so I'm not going to talk about this a lot, but just really briefly, this is how, for the IQ tests, all the tests that we do for the neuropsych data, those scores are compared to other children of that same age level, and that allows the clinician to understand where on a kind of a continuum does that child fall. Are they below average, average, or above average? And that helps us see patterns. So basically, for all the tests we do, we may do many, many tests. You would look for patterns of weakness or strength in certain domains, and that will help us understand a learning style or a thinking kind of pattern. And everybody has variability. It's normal for everybody to have variability during a neuropsych evaluation, but what's notable is if there's a certain pattern of weakness. Okay, and questions about the bell curve. Okay, so here's going back to that kind of the question about subtle autism. So the detailed history gathering is really, really important. The sensory sensitivities early in childhood, it's normal a lot of kids have sensory sensitivities, but it's part of a bigger picture. So the sensory sensitivities early in childhood in combination with other things is what would make you start thinking about autism. Oftentimes they improve. Something that I see in older kids who are coming in for a diagnosis of autism or potential autism is age-appropriate interests, but they're in unusual intensity. So maybe they're really interested in anime, and that's a age-appropriate interest, but they talk about it, think about it, draw it all the time, to the exclusion of other things. It's difficult to get them to talk about other stuff. Other friends or people may want to change the subject, and then they bring it back to anime again and again and again. So that's an example of a more subtle, intense interest that is age appropriate and might be easy to miss, but it can be representative of a restricted interest. For kind of more pronounced autism, that's a little bit easier to spot or to notice, but kids can also, if they're more subtle, they can learn to mask that. They understand, oh, this person doesn't want me to talk about this anymore, but they're still thinking and talking about it, on their own. Diagnostic overshadowing is an important consideration for kids with subtle autism, because they may have ADHD and then mild autism, but the ADHD is overshadowing the autism, and so it's been missed for many, many years because all of the difficulties are just being ascribed to the ADHD. And the same thing can happen with a language disability. So if a child has a language disability, they're not able to communicate, they're not able to express themselves or understand others. And they may also have subtle autism, but all of the difficulties are being ascribed to the language disability. And then the autism gets missed. So other things that are important to think about with subtle autism is the anxiety and mood. A lot of times kids will come to me in kind of middle school or early high school, and parents say everything was fine. They were doing great. And then they've just started getting really withdrawn and depressed this year. They're really anxious. They don't understand why. Their grades are starting to go down. I know they can do these things. I don't understand. There's a shift in kind of social expectations that happens after elementary school into middle school and then throughout middle school. So the gap can really widen between kids with autism and without autism in terms of their social development, and differences can kind of become more pronounced during that time. And so the reason for the mood and anxiety can be because that the child is experiencing that change. They don't really understand what's going on. They feel different. They feel confused and lonely. They don't understand why. They may also be engaging in camouflaging and compensating, and passing is another kind of word for that. And that's because they understand what they should be doing to kind of blend in, but it's not necessarily comfortable and natural for them to do it, but they do it anyway. And then it's exhausting and it makes them feel anxious and depressed. It's a really important thing to pay attention to. Any question? Oh, we have one question. Let's see. Is autism similar to high functioning autism? Are they both the same? So the question is subtle autism similar to high functioning autism, or are they both the same? So the high functioning autism is a term that I think is tricky, because the functioning piece, the high functioning piece, makes, if someone's low functioning, then they're kind of seen as having more severe autism, and the goal is to get them to be less severe. But if you're thinking about things from a neurodiversity standpoint, we're not trying to change people or make them less severe or more high functioning. They are who they are, and we're supporting them as best we can. So I think the term high functioning is tricky, because someone could be high functioning. They could have a very, very high IQ. They could have a 140 IQ, but they have a very difficult time. They're having a difficult time in school because they're feeling depressed and anxious because they're camouflaging and masking every single day, and they're exhausted from that. So now they've stopped going to school, and now they've stopped taking showers, and now they've stopped doing their homework. And so, I mean, would you consider that person to be high functioning? I don't know. So I think that high functioning term is really misleading. And but I think what you're saying is high functioning similar to subtle autism. I think what I think you're saying is, I think, yes, we're talking about people with kind of less severe or kind of like less pronounced presentations. Okay, so here's another question. Okay, so this is a question about diagnostic overshadowing. So they're saying, with diagnostic overshadowing, are the tools and supports for ADHD amiss in terms of how to best support them, meaning focus on the autism or the ADHD or both? So usually the supports for ADHD are not working enough. So a child may have autism or ADHD, and we're supporting them for the ADHD. So we're giving them all the typical supports we would give for a child with ADHD. So extra time in tests and quizzes, support with executive functioning, in school, breaking larger tasks down into smaller steps, but they're still having all these difficulties. Those supports for ADHD should still be, there should be ongoing, but there should be new supports that address the autism needs as well. Does that make sense? So they should both be happening. It's just hard to sometimes see the autism characteristics when people think everything is because of the ADHD. Does that answer your question? Okay. All right, so another piece I think is really important that I'd like to mention is autism and gender. So this is a rich topic. So for autism and gender identity is something I always pay attention to in every case, but especially with autism, it's a special consideration for a couple different reasons. So one reason is because autism is more commonly diagnosed in boys than it is in girls. And there are some different theories as to why that happens. Some people, there's like lots of research on this. There are some studies that are finding brain differences in male and female people with autism. They're different from brain differences in neurotypical males and females. Some of those studies have not been replicated, some of them have. So I think it's tricky to kind of go into that area, but I think we need more research. There's the extreme male brain theory, which is another theory. You can read about it in there. But another theory, I think, is that presentation for girls with autism is just different than it is for boys. And the diagnostic criteria for autism were based more on males than it was on females. And so that's who we're identifying. We're identifying the boys. And that's kind of a little bit how I lean, but I'm open to, to learning and as research goes on, but that's kind of how I present. That's how I kind of approach my cases. And so that I look really carefully at girls who are coming in with possible autism because it may look different for them. Can the characters of autism? Okay, so 2 questions here. Okay, so what is the difference between an evaluation done by a developmental pediatrician and a neuropsychologist, assuming both can do the ADOS? So a developmental pediatrician has different training than a neuropsychologist. They may do, I don't know exactly what the tests are that a developmental pediatrician would do. I'm not sure if they would be doing all of the neuropsychological tests that a neuropsychologist would do. So I'm not sure if they would be doing fine motor stuff, executive functioning, memory, academic. That's the stuff that a neuropsychologist would do. If a pediatrician, a developmental pediatrician is doing that, the developmental pediatricians I have worked with, we've kind of collaborated. And so I have done parts of the case and they have done parts of the case. But I would say you could ask a developmental pediatrician exactly what they're planning on doing. And then the next question is, can the characteristics of autism be eliminated? Or the severity reduced? Should school, okay, so can the characteristics of autism be eliminated or the severity reduced? Should school be able to provide services that will create improvement, or are there some areas that will not improve? Very good question. I'm going to hold that question. I'm just going to finish this discussion on gender, and then I'm going to come to that in 1 second, because I think the next slide will have some things on this. Okay, so the next thing so gender is important because autism, I think, can look different in girls than it looks in boys. So you have to be careful about kind of overlooking very subtle evidence in girls. And I think the research also shows that girls tend to be better at camouflaging and masking and passing. And so they are better at kind of knowing what they should be doing, but they are still experiencing, at the end of the day, they're exhausted, they're tired, they're anxious, they're feeling depressed because of the effort it takes for them to kind of pass as normal as kind of neurotypical kids. Okay, and then the last thing that I think is just kind of an interesting piece is incidence of trans identity is higher in those diagnosed with autism compared to the neurotypical population. The difference is kind of 5 to 7%, whereas they compared to 1%. There's a lot of research about that, theories as to why. I've linked some things at the end. But it's something I pay attention to and I just kind of listen for, because it's more, it should be more of a consideration in these cases, just because it's more common. Okay, so this is coming to your question about the severity. So it depends on who you ask this question. Eliminating the severity or kind of reducing the characteristics of autism, if you're asking someone from a neurodiverse standpoint, they would say, no, you don't want to eliminate or reduce severity of the child, because that's who they are. And I think that might be seen as, or might feel like, you're trying to change the child to fit in better with, or to be kind of easier to deal with, or to be better tolerated by their community, when what we might want to do is understand them better and change their expectations, and tolerate them for who they are. But what I think another side of what you're saying is, there are some things that people who have autism experience as distressing themselves, like difficulty making friends, difficulty understanding social scenarios, and those feel distressing to the person with autism. Those are things that I think we can work on to reduce their distress. And those things, and so this slide that I have here talks about kind of the goal. So the intervention in therapy, what's the goal here? So the goal, I think, really is more changing the environment than changing the child. And that looks like things like IEP, 504, educating family and friends about what the child needs and who they are. And that can then lead to adjusting expectations for difficult scenarios. So like birthday parties, family gatherings, things like, we don't expect Bobby to stay at a family barbecue for the entire time. It's okay if he needs to go into his room, or go kind of make a plan, like this is your safe room if you're at somebody else's house. It's okay if you need to take a break and go over here for a while. And we're not forcing them to stay in an uncomfortable situation just because we want them to be there. They can be there as long as they want, or as long as they need to be, and then they can retreat and kind of recharge or go on their own for a little while. So I think it depends on how you're measuring things too. So your question about kind of reducing severity, it depends on how you're measuring severity. So if you're measuring severity in terms of the child's distress, that's one thing. But if you're measuring severity based on other people's experience of that child, those are kind of two different things. Does that make sense? Like another example is eye contact. So you might measure eye contact and say, this child is using reduced eye contact. They're not making eye contact when we're having a conversation. After a year of therapy, now they're making more eye contact and they're able to look me in the eye and they're having conversation. Someone kind of in the neurodiversity world might say that's not a great measure of their severity, because looking someone in the eye makes the person feel better, but it doesn't necessarily mean the child is interacting in a more effective way for them. They may be attending and listening and talking to someone. It may even be better for them to not be making eye contact, because eye contact can be overwhelming. It can be aversive. It can be uncomfortable. And so the eye contact might be more for the other person than it is for them. So I think it depends on how you're measuring the severity, if that makes sense. What is severe? Is it the child's distress, or is it how they're functioning? Okay, someone said in the previous slide, what does extreme of, okay, so the extreme male brain theory. So it's a little controversial. I put it on there because it's one of the theories about why more boys end up being diagnosed with autism than girls. So the extreme male brain theory is basically that autism is, so that there's kind of like a continuum of gender typical presentations. Like a female presentation is more skewed towards empathy and emotional intelligence, and then the male side is more systematic or kind of recognizing patterns, understanding technical systems. And so the theory posits that for people with autism, no matter their sex, they tend to be more towards the systemizing, kind of pattern recognizing end of the continuum. So kind of an extreme version of the male brain, if that makes sense.
There are so many like laugh emojis going through my head right now, thinking about that and how ridiculous that is. So
I know.
I'm just going to put a voice to that.
No, I hesitate to even go into it because it is so controversial. And I think as time goes on, we're learning more about how problematic that theory is. But I would be remiss if I didn't at least mention it, because it's one of the theories as to why more boys end up getting diagnosed than girls. But there's so many problems with it. I mean, like socialization of gender. There's just so many different things. So that's what the extreme male brain theory is. It's controversial for sure, to say the very least. And I personally don't really know how. I think it's losing ground. And I think for me, what makes most sense in terms of how I approach diagnosis is that the diagnostic criteria were skewed male from the very beginning, because that's how the characteristics were recognized initially. So we are recognizing boys because that's who the diagnostic criteria were modeled after. That's kind of how I operate, but there's new information, there's new research happening all the time. So it's an ongoing topic. Okay, so there's kind of two ways to approach the kind of the intervention. I'm just trying to check. I know we're getting late on our time here. I'm going to try to go through a couple of these slides really quickly. So changing the environment versus changing the child. So changing the environment can look like these things I mentioned, but then changing the child, it doesn't have to be exactly changing the child. It can, I think things that go for me into that category are things like therapy. So what the therapy can help with is coping with the stress of things like camouflaging. So a child who's been identified as having autism may see a therapist to talk about the stress of feeling different, thinking different, feeling from others, feeling lonely or dissatisfied in their social relationships, feeling, confused socially. A therapist can be really helpful in talking those things through. And then that's not changing the child, but it's talking about the distress that they're feeling being in kind of a neurotypical world. And then there's lots of therapies that I'm going to mention on the next page, but I also wanted to leave time for a discussion about ABA. This is a really great article that everybody should read about ABA, because ABA has gotten very controversial recently, and it used to be the gold standard. Everybody recommended it for anybody with autism, and it's just, we've learned a lot. There's been a lot of developments in therapies. Here's a bunch of other therapies, including ABA, a lot of other therapies that are available. ABA, the controversy around ABA, if you're not aware, is that people with autism may feel that it is kind of abusive, or kind of like trying to change them to be more kind of neurotypical. It can be very repetitive. It can kind of sometimes it can focus more on eliminating behaviors than it is on kind of promoting behaviors. And so the controversy is that it's basically trying to change a child to be more, to fit into the world more. But I think ABA has evolved a lot, and not all ABA therapists do that. I think most ABA therapists are not kind of in that mindset when they're doing ABA. they're thinking more about, how do I get this child to be more independent? How do I promote some pro-social behaviors through positive reinforcement? But it's definitely, it's controversial. It's another controversial area. So that's why I listed some of these other possibilities. The problem is insurance companies are way more likely to reimburse ABA than they are to reimburse any of these other services. And so for people who really do need their insurance companies to help them pay for services for their child, ABA may be the only option for them. So it's tricky when you say that ABA can be hurtful or abusive to a child when that's the only thing that's available to that family because of their financial situation. So I think it's really complicated. And there are some good things about ABA. I mean, I think for children with very severe language delays or more pronounced presentations of autism, ABA can help them. They're more likely their behaviors are more likely to improve under an ABA framework, according to the research, than some of these other models. So if you're really talking about a kid who has very pronounced functional impairment, ABA might be the best choice, but it's really a personal choice for the family and for the child. I described some of these therapies here. You can look at that. You can look them up as well. It's really about what the financial situation of the family is, what's the best fit for the family. A lot of these other therapies are kind of offshoots from ABA. So they take pieces of ABA and they kind of make them more child-centered, more family-centered, more play-based. So I think there's an evolution of ABA that's been happening that can be more child-friendly and family-friendly.
What is your take on like family involvement in terms of like what things are we working on in ABA? For instance, if the eye contact scenario came up, and a therapist was like, oh, well, we're going to work on eye contact. I would feel like it should be very reasonable for a family to be able to say, well, that's not really a goal that we want to focus on because that's not really functional for our child. Like we would much rather work on putting on socks or, things that are genuinely helpful. And how much interaction should a family have with an ABA therapist to ensure that that's what they're focusing on and that they're not focusing on things that are trying to make the child mask into someone that they're not.
Yes, I think the family should have a huge role in that. And because it's really, the ABA or any therapy really should be generalized to the family and what the family is doing on a day-to-day hourly basis. That's when these therapies are the most effective. If they're just practiced when they're in that session, that therapy session, it's not going to be effective. So everybody has to agree on what the goals should be. And so I think the question that the family can ask is exactly what you said, which is, you can call it like a not, what is the, are you trying to get this kid to pass as normal, or are you trying to get this kid to be more functional? And if it's just to pass as normal, like the eye contact or the flapping, or any of those stereotype behaviors, that's not bothersome to the child for the most part. That's actually self-soothing for them. It's bothersome to other people. And so eliminating that behavior or increasing eye contact, that's for the benefit of everybody else, not for that child. And actually, there's a lot of evidence that shows that eliminating those behaviors, like the stimming behaviors, the flapping, increasing eye contact, actually causes a longer term decrease in functioning, because you're taking away a coping skill and you're forcing a child to do something that's uncomfortable and difficult for them, because it's making them look less severe or making them look more functional. So I think it's a really important point that the family has a big role in the advocacy of their child. The question is this making their life easier or my life easier, or the community's life easier? That's a great question. Okay, so I'm not going to go through these, but read through them on your own. If you are interested, you can Google them too. The link down there has more information about those different therapies. You can look at kind of which ones are more evidence-based, what does an actual therapy session look like? So you can go there if you want more information on those. All right, there's like a couple more things here that we're probably not going to have time for, but just really quickly, I wanted to talk about this, how to talk to your kid about diagnosis. And this is different for every family, and it's a choice for every family. Some families don't want to do this. They don't want to talk about diagnosis to their child. Some families do. I think it can be important as you get closer to transitioning age. So as the kid is getting older and they're getting ready to transition into adulthood, I find it really useful for a child to be involved in the feedback and with me as the neuropsychologist, so I can talk about what their diagnosis is. How did we come to that conclusion? Do they agree with that? What do they understand about autism? And making sure that we're not pathologizing that. So saying things like every brain is different, your brain works differently than most people in our community. Your brain works, you're better at these things, and these other things are harder. And really balancing the strengths with some of the things that they probably know or are aware of that there are weaknesses for them. So they're not feeling like this is all the stuff that's wrong with me. And I think for the most part, families are more afraid of talking about the diagnosis than they need to be, because the kid actually feels relief and they feel a sense of belonging. They felt like they were different. They felt like they didn't understand, but now they have an opportunity for a community. They have some answers to why things weren't feeling right and why they felt different. And it kind of opens up more conversations for them. So I think it's really important for many families to talk with the diagnosis with the child. And I'm going to leave this. You guys can read this slide on your own. But it's important to think about transitioning to adulthood as early as 10. And you can do those in a lot of different ways, but read this slide. And that's it. I wish we had more time to talk about that stuff at the end, but I think we covered a lot of topics.
Would you be okay if I went ahead and stopped the recording just in case anyone wants to ask questions that they were not comfortable asking?
No problem.
During the recording session. All right, so I'm going to turn off recording and we can continue.